So just to give a background to this series, we've got a series of four events like this which we'll be running. The first, obviously, remote consultations, and the others in no particular order are on responsible prescribing, circular economy in healthcare, and whole person care for sustainability. So this series of four virtual events is funded by the Health Foundation. The aim of this is to increase collaboration in the field of sustainable healthcare. And now some of that collaboration will come about in events like this, and the reason for the urgency really is obviously the urgency of the climate crisis itself, but also this document recently produced in October, delivering a net zero for the NHS, which is a strategy that was set out to achieve that. And really a lot of this collaboration will focus around the Q community, which is an online community of a group of healthcare professionals of all different types who are involved in QI. So we urge you to, if you're interested in QI and involved in it, to join the Q community. And they have a set of special interest group, one of which is that for sustainable healthcare. So it's a great place to collaborate. I convene it, and we see a lot of collaboration interaction there. So really encourage you to get involved. So as we run through these different events, there'll be a couple of sort of concepts which are threads running through them. And the first of those is the principles of sustainable practice, which our medical director, Frances Mortimer, laid out. Really with obviously the overall aim is to reduce the impact on the environment without reducing health outcomes. And to do those things, we can either reduce activity or reduce carbon intensity. And these sort of principles they're not unique to sustainable healthcare, but this cluster is I would say unique to sustainable healthcare and really useful in thinking about what solutions you might come up with. So it's obviously prevention, so primary and secondary prevention, self-care and empowerment of patients and staff, I think as well. Lean pathways, so making every step count within your patient journey and your processes. Low carbon alternatives, so we're looking at digital today. Is that a low carbon alternative? Sometimes it is, and sometimes it isn't, as I'm sure we'll discover. And then operational resource use as well. So that's about kind of the stuff that we use. So we'll be illustrating those as we go through, but just to let you know about the kind of conceptual background to this. And the second big concept that we look at is sustainable value. So here we're thinking about, obviously when we look at sustainable value, we're wanting to deliver the best outcomes for patients and populations, not just now, but in the future. And thinking about, we're wanting to do that with a minimum cost to the environment, with a minimum financial cost, and building in social value at every point. So that is the other, and this is very useful when we come to measurement as well. So these are the key concepts which will run as a thread through this series, and certainly through this section now. Without any more ado, I'll start with you, Andrew, and start having a think about how the situation in primary care. So if you could unmute yourself, and then I wonder whether you could tell me really about your journey of introducing digital consulting in Bristol and at your practice in particular.
Yeah, sure. Well, it's probably about 2.5 years ago as a CCG, we decided to start the process of implementing online consultations for our practices. And so as part of that, we initially engaged with the main suppliers on the market at that time to understand the functionality which was available. And then following that, we then sought out 5 practices who were quite keen to pilot this type of approach, so of which my practice was one. So and we then, using those practices, we then ran a procurement process really with the main suppliers to then identify 2 products of which the practice could choose which one they wanted to go down. So we just divided the products up really into 2 sort of main categories. One was more a sort of a questionnaire-based approach where you get a document coming back to the practice with the patient's feedback on. Another was more integrated with the clinical system, which the idea behind that was it took the patients through an algorithm and then pushed them gave them the options of an appointment slot. But after looking at the alternatives, even though the second option sounded more interesting, actually, we felt in some ways it was more inflexible for our practice, and we opted to go for the questionnaire-based route, as we felt that would fit our practice better. So so actually the process of implementing it was actually quite a journey, I think, really. So these products do produce quite a fundamental change to the way that you engage with your patients. And for us, it threw up a lot of issues that we hadn't fully appreciated before we started, I think. So we somewhat courageously opted to move to a almost like a total triage option to begin with, where for patients who wanted to be seen, urgently, we try to push as many through the e-consult process as possible. And for those who, weren't digitally enabled, we had a separate sort of questionnaire-based approach our receptionist ran. So, but I think at the time, it was probably too much change all at once. I think you have to change both clinician and patient behavior for this to work. I know we had targeted the patient behavior quite well. We hadn't fully appreciated the changes needed in our clinical workforce to make this work well. So we found initially it actually created work rather than saved work. And we, after a few months, we downgraded the process to more of the patient choosing whether they wanted to use it or not. And that, at that time, worked much better for us. I think if we were to do it now, I think COVID has changed everything completely. And I think both clinicians and patients are much more used to this sort of more remote form of working. But maybe a slight digression. But I think from our point of view, it really opened up a new channel once we understood the issues around it. And we managed to build a new workflow into our practice. Actually, I think it's produced quite a few significant benefits for us. I think from our patients, now that they have a choice whether or not they use it or not, actually those who do choose to use it, seem to really like it. Our satisfaction results from the questionnaires that the system produce have actually been been very good, with 85-90% of people who use it now saying that they find it very helpful and they would recommend it to their friends. So
that's a really high level of satisfaction, isn't it?
It's a high level. So and from the clinician point of view, because the e-consult system actually has about 100 bespoke questionnaires that are targeted for the particular condition, it means it goes through a whole series of questions that actually take a pretty good history, identify the red flags, particularly for those conditions. If the system determines that from the answers this patient actually shouldn't be waiting a day or two for a result, it will actually push them out and suggest they go down a different route. So those if you like someone with back pain who has a possible cauda equina, they will be pushed out and told to go elsewhere. So you don't have serious things hopefully sitting in your list waiting to be seen. So but actually, as a clinician, if you are disciplined and you read that e-consult, it makes your then history taking later with your patient much quicker, because a lot of the information has been already presented to you. So
what about elements? I think you mentioned before when we were speaking just before this event about patient empowerment. What sort of that was one of the principles of sustainable healthcare, and you thought that that you can increase that as well through this change?
Yeah, so I think in several ways. One, I think I think the questionnaires are quite well worded in that they actually try and encourage the patient to think about actually what were they hoping from this consultation. Do they have any particular concerns or worries? So it helps them to, if you like, express their concerns and think about actually what they hope to achieve from the consultation before they actually engage with us, which I think is very helpful. I think the fact it allows patients to seek advice at a time which is convenient for them, I think is very good. It's actually reduced our big surge of telephone demand on our telephone lines first thing in the morning. So
that's interesting.
So it has reduced our telephone queues and helps us provide a better service for our patients. But But I think it. And the other thing I think around is actually we're starting to use it for chronic disease management now as well. In that
Oh,
there are a number of templates which have been produced specifically for chronic disease. And again, hopefully, with going down that route, we can help people engage more with the management of their their long-term conditions as well as their acute illness.
Okay, that's been really helpful. Thank you. And in terms of working at a systems level, I think you mentioned you've been working on a dermatology pathway. I'm just wondering how that's increased the sustainability of that pathway through introducing digital elements to that path.
Yeah.
So
I think that's
service.
a really interesting pathway, because that goes beyond just the online consultations we've talked about just now, and actually focuses on other elements of, if you like, remote consultations as well. In that, I think for a year or two we've been using a tool which allows us to text patients. And actually, as when COVID hit, the company who we were using for that, a company called AcuRx, actually developed quite a lot of additional functionality within that, which allowed patients to send documents or images to us, and us to send links to documents back to them. So, and this actually opened up some doors in the dermatology pathway. And that as a practice, I have a keen interest in dermatology myself, and I do dermoscopy, so that it allows, if someone phones the practice with a skin lesion, we actually get our receptionist to send them a text straight out to say, please send us a photo of the lesion. And the idea then is that we can look at that, we can then either say we can treat that, we need to see the patient, or this patient needs referral on, and then we can, we currently use ERS as the electronic referral system, the national system, then to send a request off to the dermatologist with the photos attached. And if I've seen and done dermoscopy, I can send that dermoscopic image as well. And that then allows the dermatologist then to look at that and then say, like we've just done with the patient, they can say back to us, here's the treatment that you should be doing, you can go ahead and manage it yourself, or I'd like to see that patient, and they may then choose a video consultation or a face-to-face, or they may even get some dermoscopic images done by medical photography and prior to a remote consultation for that patient. So it's opened quite a lot of doors up in that pathway to manage people in a slightly different way to the way we were doing before.
Yeah, it sounds very lean, and also saving a lot of patient travel, and I imagine a lot of time having to go up to the hospital for all those appointments. Yeah, wonderful. Thank you, Andrew. So so Shanti, I think it's quite interesting, because even though we sort of identified that there may be some environmental benefits actually having the switch to video consultations, it sounded like you actually were driven to introduce video consultation at Barts, actually driven by some concerns about sort of social sustainability and access to your services. So I was wondering whether you could tell us a little bit more about about kind of your journey, as we just heard about Andrew's, to introducing video consults in Barts.
Yes, so I work at Newham, and so people who aren't familiar, it's in the East End of London, and it's a very deprived borough. It's also, more than 70% is from ethnic minority populations, and it's one of the youngest boroughs in the country. So what we then have is a lot of people with chronic disease diagnosed very early on, who then spend a bulk of their life traveling to multidisciplinary hospital appointments. And a lot of people really can't afford to take too much time off work. A lot of them provide carer support. There are young mums with kids. And so we found that our non-attendance rates were very high when we started doing this work in 2010, actually. So we initially got some money from the Health Foundation to look at whether it was possible to just replace some face-to-face appointments with online appointments where we didn't need to physically examine people, and just look at feasibility. And the feedback from patients was very, very positive. And we went back to the Health Foundation and got some more money for a 2-year piece of work. And what we realized was we couldn't do video consultations in isolation. What we really needed to do was to co-design the patient pathway to make it more user-friendly. And so we started looking specifically at people who repeatedly failed to keep outpatient appointments, and whether they could proactively book their own appointments and make it more proactive and responsive. And a bit like what Andrew was saying, it fundamentally changed the way we provided care, because patients said that it became more a conversation of equals, and they felt equal partners in their clinical management rather than coming to your clinic and then you running the consultation. And so we, along with Trish Greenhalgh and our academic partners, we managed to get some funding from the NIHR for a 3-year project. And what we then started looking was online consultations in various specialties. And I can notice some questions on Slido about outcome measures. And what we were able to demonstrate was both quantitative and qualitative outcome improvements, purely because of greater engagement from patients and carers. And really, we looked at the dynamics of the clinician-patient interaction. We looked at organizational impact, and we looked at impact of national policy. And then again, very grateful to the Health Foundation for awarding us the Scaling Up grant in 2017. And what we've been doing as part of Scaling Up is rolling out online consultations more widely within Barts Health. So we've got about 57 services at the moment using online consultations, and they vary in terms of multidisciplinary teams and services and needs. And we've also been working with some trusts nationally, because we want to look at it in different demographics. Mm-hmm. And, you know, for example, the team at Oxford have got people who travel, they have international travelers coming for very specialist care, whereas at Northumbria, it's more a question of geography and wider distances. There are also different ethnic groups. And actually, sustainable environmental care was not part of what we set out to look at, but Jo will fill you in a little bit, because she's been doing loads of work around patient focus groups and questionnaires and looking at the wider societal and environmental impact of trying to do more things non-face-to-face.
That's right. Thank you very much, Shanti. That's a really good summary of where you come to so far. And Jo's going to fill us in about some of those social and environmental elements. So Jo, I know that you've presented before and collected data on the environmental sustainability of your service, particularly related to travel. So I was wondering whether you could just tell us a little bit more about what you've done so far and what you plan to do in the future.
Yes, okay, great. So we've been looking at this for a while. So pre-COVID, we did a very simple survey in the outpatient clinic. So we did it in Shanti's diabetes clinic, and we also did it in the specialist tertiary clinic. And we looked at how far patients were travelling to their outpatient appointments, just using a very simple survey. We also asked them things about how much time they had to take off work, how much it cost them, and things like that. And so we found that for the local clinic, they were travelling about 5.5 miles return journey to their clinic appointments, but in the specialist clinic it was about 26 miles per return journey for each appointment. And so we were very aware, with about 1 million follow-up appointments at Barts Health a year, that was a huge mileage, and that with using remote consultations we had potential. COVID, we've been doing the patient feedback survey after all the video appointments, which I'm quite sure lots of trusts are doing that. Yeah. And we've had about more than 3,000 responses to that patient feedback survey. And on that survey, we're including postcode and which hospital site the clinic service is based at. And if the patient had come in face-to-face to their appointment, how would they have travelled? What transport would they have used? So from that information, we can calculate carbon footprint savings for our video appointments. And we haven't actually done it yet, but we're actually going to work further with the team at the Centre for Sustainable Healthcare to look at what the carbon footprint savings are from those 3,000 responses that we got. So that's our plan at the moment.
Great, thank you very much, Jo. That's really helpful to see what you're doing, because I know you've collected a lot of data. It's wonderful that you've built that into your system so far. So what I'm going to ask, we're going to ask just Ben if we'll move to you next, we'll move to you next. So just starting out. So it's really great that you're able to join, actually offering that sort of slightly different perspective. So can you just tell us about where the main contributors are to the carbon footprint in digital services and healthcare, please?
Yeah, of course. So when I first started working in this area a couple of years ago, it was really a hidden topic, and there was this kind of general assumption that digital is better and greener, and just a good thing, really. And it usually is, but we have to kind of think about it through this net gain lens. So what's the kind of sustainability costs of running an infrastructural ICT system against what are the sustainability benefits that it's creating? And generally speaking, there is a benefit overall. But there are exceptions. So some recent work that we've done as part of the NHS Net Zero plan showed that some very short journey avoided trips for telehealth consultations instead actually showed an increase in carbon rather than a decrease. So, you know, there are exceptions that prove the rule. But in summary to your question, you know, digital does have a large impact. It's similar to aviation and growing. There are great examples like Bitcoin, the Bitcoin system that's got the energy consumption of a whole country. So, you know, it's something we need to think about. And in terms of sort of subdividing it up, the critical areas are like hosting choices. So where do we keep our data? Public cloud providers are fairly good, but there's some data transparency issues there that we're working on. We're also living in a world of exponential data increase. So there's some interesting questions around how long do we keep data for, and you know, those kind of things. Networking as well, how much data do we send down the wires? So most of the data that goes, something like 2/3 of internet traffic is video actually. So with COVID happening, there was a real spike in that. So thinking about our video resolution is a really important one. And then lastly, end user devices. So, you know, all the things we've got in our homes. We should try and have as few of them as possible. 80% of the life cycle energy in an end user device is embodied in the manufacturing phase.
The manufacturing, yeah.
So we want to reduce that down as much as we can, really. It's the kind of single biggest measure that you can do there. If you wanted to look at some useful guides, Greenpeace USA have done some great ones. Click Clean. A guide to greener electronics. They're a little bit dated, but they're great kind of entry-level things.
Yes.
As well, so I'd recommend looking there.
Great, thank you so much. That's a really good summary, Ben. I really appreciate that. That's a different perspective. So we'll just move to Slido now, and I'll just have a quick look at these questions. And if you do have questions that you'd like to direct to a particular speaker, please do put that in your question. Great. So let's take a look at these now. Good. So I've got a question here for Shanti, and if that possibly it could also be relevant for Andrew, I think, as well. How are you managing to interact with elderly patients who don't have access to digital tools? So I can see that it's obviously a bit of you obviously try to improve social access, but there could be downsides there as well, or difficulties.
That, you know, we are very aware of these issues, and we've got various groups at Barts Health that are looking at equity and access. And one of the ideas at the moment is to have volunteers in the community to work with people who are struggling to access. So the idea is that for people who aren't confident that they can receive a phone call prior to their video appointment to talk them through how to access it. But we're aware also, you know, there's other things that we need to do for people that haven't even got the equipment and things like that. And it's very much about working with the community, because there's a lot going on in the community about digital access in general. I think there's some repurposing of equipment going on as well, and different initiatives that are taking place that we're trying to link up with.
The other thing I would just say from personal experience. So I think making preconceived judgments about how people access is probably not appropriate, as I've discovered. So I often look at older people and think they probably won't accept it. But actually, a lot of people, especially post-COVID, have been so used to keeping in touch with family and friends around the world that they've started using Skype and online technology and Zoom and all sorts of things. And where it does help is you often have to have carers taking time off work and accompanying older people for hospital appointments. And I've often found offering people a choice. Obviously, one size will not fit all, but very often a carer or a son or somebody has been quite happy to log someone into an online consultation and then sit with them, maybe log them off, and then and that way it seems to work better. They don't have to make a journey, especially a lot of my patients are shielding at the moment, and they don't really want to use public transport and make a journey into hospital. And people just find it financially viable for carers to help assist family members to do online contact, which we're finding a lot of over the last few months.
Great, thank you so much. That's really great. And what about from a primary care perspective, Andrew? What are you finding?
Yeah, well, this was one thing we were very aware of when we implemented the system, and that we were aware that not everyone would be able to use it. So we were very careful in the protocols we put in for our receptionists that, you know, when we were encouraging online consultation use, we were, you know, checking with them if they felt they could use it and make it clear if they could phone back if they're having problems. Another thing we did was that we purchased an iPad, and we had one of our receptionists for a few weeks in the waiting room actually trying to show people how to use it and show people how easy it was to use as well, to try and provide some education. But that was something we couldn't sustain longer term. We did that probably during the first month of our implementation as part of the sort of encouraging people to use it. But there is wider work going on in our CCG around looking at digital exclusion and how ways of working with the community to try and improve digital literacy within particularly in some of the more deprived areas of Bristol. So, but that's a piece of work which is really only just starting to kick off. So it is not yet that far advanced.
Great. Thank you so much. That's brilliant.
Just a little bit to chip in on that previous one. I know that one of the key considerations in the digital system design that we do is making sure that some of the older technology is available to use in things like app-based tooling. So I think quite a kind of timely example is some of the COVID-related apps have struggled to check people in and things like that because they've been reliant on some of the more modern Bluetooth technology in mobile phones. So you know, there's a great kind of topical example of how to try and limit digital exclusion means that we sometimes have to make sure that we're enabling some of the older technology, because some of the devices that poorer people will have won't necessarily be the latest models. So there's a bit of support there.
Yes, I think. So we've got a question here saying many community workers deliver virtual consultations working from home. Is there a consideration in NHS digital around the carbon efficiency of sort of home working versus large centres? So that I think will be interesting, and I think make us think about sort of the way we use our estate as well, sort of the buildings maybe, which I know is something that Andrew thought about. Maybe we can touch on sort of individual and organisational ways we can reduce our footprint. That would be great. Thank you, Ben.
In terms of this question, yeah, we actually did a study on this. So in our particular context, based on our mix of office accommodation and staff commuter travel data, we showed that we made a carbon reduction by large scale shifting to working from home, and we scoped in energy use at home, energy use in the office, the energy use involved in running the ICT systems as well. So as well as the travel, of course, the travel savings. So yeah, that it's fairly simple to do those kind of number crunching exercises if you've got the right data sources. And I think this is one of the things that your project would hope to help.
Yeah, that's one of the things Inga's working on. I know you've been collaborating with her. Yes.
Yeah, exactly. Yeah.
And I suppose it would be quite interesting, Andrew, I think you were saying as well that you'd found that obviously it's quite difficult in large hospital trusts, isn't it, to decommission buildings essentially because they're big estates. It's probably something we'll always fill. But I think we were thinking that there would be perhaps implications for GP surgeries, which are smaller concerns, to maybe downsize a bit if there was more working from home. Is that?
I think in primary care, what we have at the moment is actually quite a significant influx of staff. We've got the new primary care networks forming, and in being able to employ, more sort of clinical roles as part of that, and that's had a problem. I think the primary care estate has it's been fairly pushed for quite some time, really, with lack of capacity. So and having more staff coming in is actually, I think we're all finding that we just don't have places to put them. And so actually we think online consultations and remote consultations does provide an opportunity where actually you can structure your day more, where you have a slot when you are doing answering e-consultations or doing video or telephone consultations. And actually we can look at the way we use our space differently. We're hoping shortly to digitize our Lloyd George, which will free up a room we could then convert into 4, if you like, clinical booths for remote consultation. We could have staff working from home, and I know some of our GPs who have young families, that could actually provide a better work-life balance as well. So
building some social capital there as well, as well as saving some carbon. Yeah. Great. Okay.
Yeah.
Really interesting. Thank you, both of you. That's really helpful. Great. So just thinking about our next question here. So it's a question here from Alex Harvey saying, do any of the attendees have a secure data set showing a clear DNA reduction as a result of implementing the virtual consulting, and what the percentage impact was? So I suppose this touches on the sort of the lean aspect and making sure sort of reducing waste in the system as part of the virtual consulting. So yeah, any data there, Shanti?
We have published, there's a lot of stuff that we've published which is available on the Health Foundation website. So we looked at non-attendance rates in my diabetes service, for example, using face-to-face versus a mix of face-to-face and virtual consultations. And what we showed was it really is important to do 2 things. One is the technology that is used has to be very user-friendly. And 2, you have to make wider transformations to the outpatient pathway. So you're not just technology focused, but you're actually making the whole pathway more user-friendly. And when you do that, we showed at the start of our work in 2011, the baseline non-attendance rate was anything from 33% to 50%, depending upon the age group. But as time went by and people got more used to online contact, and the software that we were using got more user-friendly, the DNA rates dropped to about 26%. And then we started actually creating more user-initiated contact. So we would give people fixed appointments when we needed to physically examine them. But in the interim, we asked people to book an appointment depending on need at fixed time slots. And we found the DNA dropped to about 11 to 13% for the same group of people. We also showed an improvement in glycemic control in the diabetes clinic, which reflected probably greater self-management skills and greater engagement. And that's been something that has been replicated in other services. So I think the key to it is making sure that the technology is not something that requires a postgraduate qualification to use something that people can use very easily and readily, and not to do it in silo, but to make sure that the whole pathway, blood testing, booking appointments, feedback of results, clinician-patient interaction, all of that is more user-friendly and co-designed.
That's really helpful, Shanti, and great that you've got that that data. Was that baseline, that DNA, was that the DNA for face to face, or for the big? Yeah, it was. Okay.
So we took people who had done at least 2 consecutive follow-ups, because we found a lot of people tried it once and didn't try it, or didn't like it after using it for the first time. So we wanted to make sure they were persistently using it. Also, it required people to get the hang of it, really. And so we took the baseline face-to-face, and then we took a mixed match of face-to-face and virtual for the same group of patients. And we have actually published a fair bit on quantitative and qualitative outcomes from all our projects so far. The references are on our Scaling Up site on the Health Foundation.
Great, thank you very much, Shanti. It'd be great to have that link. Yeah, and I think also you've touched on our sort of our next question really, which was looking at sort of patient outcomes really. Oh yeah, it sounded like as well the outcomes had actually improved a little bit in terms of patient empowerment and actually managing their condition better, which is interesting. So just moving on to our next question, this is for Shanti and Joe. Is the transportation of prescription medicines to patients following a virtual consultation being included in the sustainability data? It was a really good question because, just thinking about the sort of the travel aspect and sustainability.
So I personally don't prescribe. We suggest to primary care colleagues, and then the prescribing is initiated by our primary care colleagues. So we have electronic prescribing within the organization that we are using within the outpatient pathway. But in terms of patients visiting us for outpatient appointments virtually, we kind of do a standard letter to primary care, and Andrew probably knows how this works better.
It's perfect having Andrew here. Yeah, any changes do you think to prescribing and that kind of thing? So I know you think you've had kind of remote prescribing for some years, haven't you? Really, you just go to the pharmacy. So
I think there've been quite a few changes in prescribing predating COVID. Really, I think so. From our point of view, I think EPS, electronic transfer of prescriptions, electronic prescription service has been key to driving that change, and we've used a lot of techniques around that. EPS4, which came in during COVID, has taken that further, which means now we can I think we transmit pretty well all our prescriptions electronically to the pharmacists. So that reduces, toner cartridges, paper, travel between the practice and the pharmacy, both for patients and pharmacy staff. So I think electronic transmission of prescriptions has been, quite transformational, really, I think, from that point of view.
Yeah, it's an example of a technology that's been there for some time, but is still fit for purpose, and good to be taken forward. Fantastic. So I think we're running a little bit close. I'm just wondering if you've got time for one more question. So just wondering whether to unpack this now. So there's one. There's lots of good questions coming up here. So we will answer some of these during whilst you're in the breakout rooms, and they'll be available to view afterwards. I think probably so there's a question here about looking at health inequalities and whether they worsen or improve following the move to virtual. I don't know whether Joe, you might be able to answer that, because I think you've been
that is something that we are looking at, because we're aware that some people it's going to be great because it's going to give them access to care that they didn't previously have, and that has been an issue, and that has driven some of the changes pre-COVID. But currently we are gathering data, and we've got a small working group at Barts actually trying to look at the people that are actually using the appointments and what the different demographics are. And on our patient questionnaire, we've got demographics data. So we're definitely looking at that. But I can't say at the moment. There's definitely going to be winners and losers in the system. And I guess it's about trying to optimize things so that more people can access it and gain the benefits from it. But that is work in progress. And there's various initiatives going on across the community and in the trust as well around digital inequalities and access. So
wonderful, thank you. I think you make a really good point there, Joe, actually, that this is all work in progress, and the work's been massively accelerated due to COVID and sort of skewed in a way that we but I suppose this provides a good link to the next section, really. Just the key is kind of, you know, what role do these have? Not that it's going to be one, it's either going to be all video consultations or all face to face. You know, what is the right method to use in certain situations, whether that be specialty specific, whether that be related to the patient or the patient condition, because and often that comes down to being, I think Andrew had mentioned on a previous conversation that we had, it very much a clinical decision often as well. So it requires a lot of collaboration, as many sustainability problems do, or complex problems, like collaboration between clinical staff and many other different sectors. Yeah, Joe and Shanti and Andrew, did you use sort of co-production methods when you were setting up your services at all?
So we had a patient actually as part of our core group to start with, actually, who worked very closely with us.
Yeah.
And then as things progressed, we had a patient advisory group who we consulted with. And then some of the patients from that group sat on our project steering group. So there was nice continuity across the groups. And yeah, they were quite vocal in feeding back their ideas. Yeah. Sometimes it's quite hard to engage the ideas that you need. There was a lot of discussion over whether they liked the idea of video. But yes, but they did help us with the progress of the project as well. So yeah, and viewing documents for us, viewing the results, and helping us make sense of some of the findings and things like that.
Great, thank you very much indeed. That's really useful. Andrew, did you have any involvement from your patient?
So we engaged with our patient participation group. So we actually first took the idea to them, saying that we were, because I think our initial drive was we were aware that you know, we were running out of capacity for same-day appointments, and we looked at this as a solution to that. So so we had some initial discussions with our patient participation group, got their feedback. We then, once we'd gone through the procurement process, we then brought the tool back that we'd selected to use and demonstrated to them to again get further feedback and talk about the way that we were planning to implement it, and then, you know, ask them for their suggestions, their thoughts about, you know, what potential issues could we face. And I think they were particularly concerned about digital exclusion and how we ensure we didn't disadvantage those who were not happy to use this type of technology. So and that really helped our thinking about how we ensured that we catered for that group of people.
Thank you, both of you. That's really helpful point. Great. So just going back to the Jamboard. So if thinking about moving now into sort of the second section, which we're thinking about what have we already got and what would we optimize, and I think there were comments actually in this section, also the other section, about having the option for people to see clinicians face to face. And I think this is really interesting, because I think that makes absolute sense. I'm just also wondering, though, thinking about what Andrew and Shanti said about, and Joe said about, if you're introducing digital, you have to redesign the whole pathway really to make it work. So if you are redesigning the whole pathway to include digital, how do you then have a sort of a face-to-face option as well? How does that fit? It'd be really, I think probably primary care more flexible, but yeah, maybe if we hear from both of you. Shanti, what are your thoughts on that?
Yeah, so this is an interesting one. So initially, for almost 6 years, the way I did the whole thing was to have a mix match of face-to-face and online slots in the clinic. So I would have about 2 or 3 appointments at the start of the clinic and 2 or 3 appointments at the end of the clinic, and you know, have the middle with face-to-face, so that people could log in and go to work or do it in their lunch break or whatever. And people were always given the option to come for a face-to-face that morning if they changed their mind or there was something there that needed physical examination. So the slot was still there. You could just flip them around. Economically, that's not the best way of doing it, because your bigger cost savings come if you can release physical space and clinical infrastructure. And so we did some cost benefit modeling with our finance teams, and the feeling was it's better to have a virtual only clinic or rather than a mixed clinic, which is what I'd been doing for about 6 years. And so I hate to say this, but I still haven't changed it because the thing is that's, you know, it works for me. And I just tell people, I've booked you a video appointment in 3 months. If that morning you wake up and you feel you want to come, just come and we'll flip the slot around. But financially, as I said, it's probably not the best way of doing it. So a lot of people who are being set up now are doing virtual only. But then that brings up this question that was brought about whether if you saw somebody online and then decided you actually did want to do a face-to-face appointment, all our clinics are so overbooked, there's no place to bring them back quickly. So I think you have to look at your own service and look at how best you design this and whether half the clinic is set up or some people in the multidisciplinary team do a virtual only and some people do a mix, so it allows you a bit of flexibility within the system and the pathway. So I think you can't generalize that, and I think you have to talk with the whole team and look at what best suits you. Yeah,
thank you, Shanti. Andrew, I'm imagining you have a bit more flexibility in primary care.
Yeah,
is that right?
We're a lot more flexible, really. I think one, the patients are fairly close by on the whole, so so we have specific sessions of online consultations on it. There might be the second half of a surgery. We can then look at those. We can then decide I need to give that person a call, or I can text that person. We can do that there and then we have some slots later in the day. If I think I need to actually see this person face to face, you can then bring them back for either a video or a face-to-face consultation later in the day. So and quite often we have that discussion with the patient. So someone may have a painful shoulder. I'd think about, could I actually do a video examination of this shoulder, or do I need to see it face to face? So, you know, there's a bit of a clinical judgment and a bit of actual patient preference as well. And, you know, what do they feel comfortable doing? So, you know, I think and again, by doing it that way, as we look at our estates, it's giving us the flexibility then to have, you know, a clinician working in not from a consulting room for certain parts of the day, so you can free up more clinical space for other clinicians to use.
Great, thank you so much. That's really good. So I think what we'll do is just one more point I wanted to pick up from the sort of stop doing side of things, and then just to kind of just before we finish, I think Ben's got some really interesting nuggets of information which we'll close on, which just sort of a counterpoint to some of the clinical elements. So so just to pick up on the element at the end, really, some people said that they would stop doing things like breaking bad news when people are at home, and also not having consultations if people can't have privacy. And I know that, Shanti, you've done a lot of work on the patient experience of video consultations, and some of these things are difficult to juggle. So I just wondered whether you could just sort of offer maybe a different view to sort of some of those things which may seem like barriers and we should stop using video consultations for.
Yeah, it was a real eye-opener for us because we got an NIHR program grant called Vocal, which was led by Trish Greenhalgh, who was working with us as our academic lead from Oxford. And we looked at specifically this whole issue of cancer care in a tertiary site within the hepatopancreatic biliary unit at Barts Health, and they were getting people traveling long distances with carers for frequent appointments. And like most people, we thought we would not be able to break bad news and it was inappropriate to do this online. But actually, we were quite surprised when we interviewed a lot of patients, and we actually filmed a lot of these things at both ends with consent for the research. And surprisingly, many people said, when I come to clinic and I make a long journey, and I've often traveled alone, and then I'm sitting in the waiting area, and then you call me in and you break bad news, and then I have to make the journey back home on my own and use public transport, and it's all terribly traumatic. I'd much rather you broke the bad news when I was at home, because then I'm in a physically comfortable space and I have family around, I can have a cry, I can make a cup of tea, and then I can get on and discuss this with others. And we've actually got some very powerful films we made of this, and we published our findings in the vocal report, which I again, that's published, and if people are interested, I can send the link. So that was quite surprising. I mean, obviously, again, one size won't fit all, and you probably do have to discuss this with people. But we were quite surprised when many people prefer to have more sensitive conversations online. I mean, I do the diabetes clinic, and I often discuss erectile dysfunction with patients, and people, again, say it's far easier to have more personal, sensitive discussions from home, or rather than in a clinic, for example.
Really
and cramped places, we've done a little do's and don'ts guide for patients and staff, and we've produced a little YouTube video for patients about how to prepare for an online consultation. And Sarah Shaw from Oxford has produced some guidance for primary care, which is on the RCGP website. And a lot of this is available on our website, again, about preparing for a consultation, both for the patient and the health professional, which we can share.
Lovely. Thank you very much, Shanti. So, we'll finish up that that element there. And just before, just to kind of also make sure that we've got the environmental side covered, Ben, I just wanted to invite you just to say a few words about the other impacts that are sort of hidden of digital care, so not quite apart from the carbon footprint. So just a minute or so on that, and then we'll close. It's really useful, really interesting. Thank you.
Thanks. So there was a great question about the environmental and social justice issues of hardware production, which is something we're thinking about. So in our recent annual report, there's a load of case study info about what we've done to reduce the energy and carbon of our data. But of course, there's a whole range of other stuff around rare earth metal resilience, modern slavery in the supply chain, a whole bunch of environmental and social considerations that we've got to be thinking about. And it's really a great segue into another one of these sessions. So around circular economy. So clearly from our ICT hardware perspective, if we can get 2 or more life cycles out with a bit of kit, then we're going to make a step reduction in the kind of broader range of sustainability embodied impacts that we've got in that hardware. So that's a fantastic opportunity. And then just a quick plug for a couple of interesting things that you might want to go and look at. There was a fantastic dispatches program on Channel 4 2 Mondays ago called something to do with your online habits. I can't remember the exact title, but it's all about the hidden sustainability impact of online stuff. And then there's some really good government materials as well. So in the greening ICT section of gov.uk that I can send some links out to. But if you did want to have a think about how green your current setup of your ICT systems are, there's some great tooling that's available to use as well there. So it's a good way into the subject.
Thank you so much, Ben. As I said again previously, it's really helpful to have your different perspective as well, with the really great perspectives we had from Andrew and Shanti and sort of primary and secondary care. So this really concludes this workshop. So thank you all very much for coming. I know we've had a sort of really diverse group of people and who are very enthusiastic and got such a huge amount of skills. So thank you for coming and participating so fully. It's been great to have you here. And finally, I mean, just absolutely thank you so much to our speakers. Thank you, Shanti. Thank you, Jo. Thank you, Andrew. Thank you, Ben, very much. You spent some time preparing. We've had conversations over several months, and yeah, I just really want to thank you for your time and your generosity, really, and sharing your deep thinking about this and your wealth of experience. So, if you want to come off mute and do a round of applause for our speakers, that would be really special. Thank you very much. It's a really lovely session. Thank you very much.
Thank you. And I can see Rosie there, so I just want to say a big thank you to the Health Foundation, because they've kind of stuck by us for the last 10 years. So big thank you for funding all the work.
And they funded this series of webinars as well. So yeah, we're very we're very grateful. Just before you leave, I just want to say thank you so much. It was really lovely to have you here. I'm really glad you could come. Yeah, and I also want to say thank you to the team. There's been a lot of work behind the scenes to put this together, and we couldn't deliver this without everyone's help. So yeah, sort of Inge, if you just raise your hand there, Inge's been great help, as has Rosie and Siobhan, and then Marjorie, who's been our tech support as well, who is currently not visible. I can't see you actually. Yeah, thank you all very much for your help. That's wonderful.